Swear at me in Spanish.
Okay. All right.
Okay, welcome everybody. We are very happy to be here today. The last webinar of the day, the third of the day. We're very happy to have Dr. Hirst and of course Pancornea. I really want to thank Pancornea and Guillermo Amezcua for this webinar. I want to invite, to everyone to the next Pancornea meeting in Buenos Aires, 2020, 5 and 7 November. It's going to be a great meeting between Pancornea and the Ibero-American meeting, the third edition. So it's going to be in November. We have time. We really hope to be safe at this time and we can go back to the personal meetings. So thank you, Pancornea, again. Thank you. Gracias, Guillermo, por esta oportunidad. We have 6 more minutes. And we want to tell you guys that tomorrow we're going to have a great talk. Gustavo Servino is one of the survivors of the Andes tragedy. So we're going to be talking about leadership, communication, work team, crisis. It's going to be great, a very emotional and very interesting talk. It's tomorrow, 3 p.m. Argentina, 1 p.m. Mexico. We want to know where are you guys from. Every time we ask you where are you from right now. Alfonso, it's here. Welcome, Alfonso.
Hey.
How are you?
Good, good.
We are all set. We're waiting to be on time and waiting for the rest of the attendees. So we are 50 people here. And we have people from, see, Ecuador, Abraham from Venezuela, Venezuela again, Fabiola.
Abraham de México, de México.
México.
Abraham René de México.
Bolivia.
Un amigo.
Okay, perfect.
Alfonso, ¿dónde estás ahora? ¿Estás en Miami o...?
En Miami, sí, ahora.
Miami.
Sí, aquí estoy en mi casa. ¿Qué tal todo?
Bien, todo muy bien. Estamos acá haciendo esto que se llama la previa, nos ponemos a charlar con la gente, nos gusta contarles un poco qué se viene en los próximos días. No sé si llegaste a ver lo de mañana, sé que a vos te va a interesar porque trabajas mucho en equipo. Gustavo Servino va a estar con nosotros, un sobreviviente de los Andes, va a hacer una charla increíble. Así que bueno, todos prendidos ahí. En vivo no va a quedar grabada, a pedido de él, así que somos muy respetuosos de eso y creo que bueno, es para aprovechar. Y hoy, today we have Dr. Professor Hirst. We're very happy to have you. It's an honor to be with you today, Doctor. And let me see, this is the introduction for you. We're waiting 3 more minutes and we start with the webinar. Guillermo, you want to share something with us?
I just want to thank Dr. Hirst for accepting the invitation. It's 6 a.m. right now, almost 6 a.m. in Brisbane, right, Dr. Hirst? You're in Brisbane?
That's right.
Okay. And so thank you very much. Dr. Hirst, we're going to try to do this as much in English. We'll have some parts in Spanish, and I will translate, or maybe Alfonso or some of the panelists will translate to you what's really important for you to know what we said. Okay?
That's fine.
But you can feel free to speak in English. Most of the audience understands English, and especially your very elegant English from Australia. So thank you very much. And thank you.
I'm sorry for this picture. This is a Sydney photo, right? I'm sorry.
It's beautiful. It's beautiful. It represents Australia.
I actually work in Sydney as well.
It's not your city. Yeah.
So thank you to the Ophthalmo University team for helping and supporting Pancornea. I don't know if Alfonso wants to say something on behalf of the board of Pancornea, because our president, Dr. Juan Carlos Abad, had a personal issue that prevented him from being here with us. He regrets it deeply. So Alfonso.
Yeah. Well, basically, Dr. Hirst, thank you again in name of Pancornea for being with us today. So I'm not sure if you're familiar with Pancornea, but Pancornea is the Pan American Cornea Society, and basically we try to help the ophthalmologists in the Americas and support them as much as we can with from webinars to wet labs to conferences, and also we have a new website that we just created, and where we share articles with the members. Also, we have an annual conference. Next conference is going to be in Buenos Aires. Probably, I'm not sure if it's going to be this year in November, but that's what we're aiming for if the coronavirus allows us. If not, we'll move it to next year. But you're more than welcome to come. And I don't know, Guillermo is also a member of Pancornea. He's also a member of the board. I don't know if you want to say anything else, Guillermo.
No, I mean, I think you covered everything. Dr. Hurst did supported one of our first events from Pancornea back in four years ago at the WOC, at the World Ophthalmology Congress in Guadalajara. We had I think it was almost a 3-hour session on Prerygium that was very well attended, and there was a lot of discussion. Many experts in this field presented data. Dr. Escaf, Dr. Ryan Sayan Basu, Ernesto Otero, everyone presented techniques that they use in their academic institutions, and our keynote speaker was Dr. Hurst, and I think everyone enjoyed it. And many people ask Ophthalmo University to do this topic, so they asked Pancornea, and we're happy to do it.
Happy to have Pancornea with us, Guillermo and Alfonso. Thank you so much. We are all set, guys. 5 p.m. o'clock here, so we are ready to go. I'm gonna stop sharing my screen, Dr. Hirst, and you can start whenever you want. Let me see.
All right.
Before he starts, I just want to briefly introduce him for everyone that's in the audience. So Dr. Hurst is a professor of ophthalmology in Australia. He did his medical school and his internship and his ophthalmology training in Australia. He won many awards, and his CV is very long, so I can't go over it. But then after that, he traveled to Baltimore, where he was a fellow in cornea at Wilmer Eye Institute in Johns Hopkins, and also a neuro-ophthalmology fellowship with Dr. Neil Miller, and where he stayed on faculty, right, Dr. Hurst, for a while?
Yes.
Yes,
another 5 years.
Another 5 years, and then became a chairman at St. Louis. And I think in '86 you went back to Australia, right?
That's right.
And has dedicated a lot of his research and training in ocular surface disorders. And I think since 2008 he's dedicated his practice exclusively to the surgical, to the surgical intervention of pterygium and management of pterygium complications. And he's published significantly on this topic. So thank you very much.
All right, I'll see if I can get this working.
Perfect. See, it's already perfect.
Okay, well, thank you very much for inviting me. I've been given a basic rundown by Guillermo as to what he'd like me to talk about. So are you seeing just the principal screen, or are you seeing also the advancing slides?
We see the advancing slides too.
Yeah, you can do it. You can.
There we go.
Yeah, that's perfect. Very good.
All right. Now, I'm sitting in my office here in Brisbane, Australia, 6 o'clock in the morning. And to my knowledge, it's the only dedicated pterygium center in Australia. And it's just possible it may be the only one in the world. And I'm hoping I'm going to be able to show you why I have dedicated myself to just this one specialty. Now, perfect for Prerygium, I have to disclose my financial involvement. Basically, I own the trademark for this, but I have to say that directly, apart from treating patients, I get no financial reimbursement for this. And this is an acronym. It stands for Perfect Extended Removal followed by Extended Conjunctival Transplant. I have to say, many years ago when I coined this acronym, I thought it was really very clever. Now, of course, I'm a little older and I realize that wasn't all that clever after all, because like everything else in this world, it isn't perfect. But I believe it comes as close as possible to that. You're all aware of the treatment of Prerygium in the Middle Ages. People tied in chairs, no anesthetic, horse hairs put under the Prerygium and the Prerygium avulsed. Now, you might think that I'm exaggerating, but in Australia, there are still a few people that just avulse the Prerygium, just pull it off and cut it off. Not with horse hairs anymore, but to consider the possibility that a middle-aged treatment is still being used in Australia is frightening. So in 1976, after I'd completed my training in ophthalmology in Melbourne, I went over to the Wilmer Institute, this is the Johns Hopkins Hospital, and spent 7 years there. Now, I have to highlight that during that time, I virtually never saw a Prerygium. I think I could count on one hand over the 7 years how many Prerygia I actually saw. There are some pretty obvious reasons for that. And in 1986, I came back to Australia. This is what all Australians look like. Suntanned, lying on the beach, exposing themselves to a whole lot of UVB. That was one reason that I started deciding that I would change my research from endothelial function and morphology, which had been my research up till then, to this disease. This gentleman who showed up in my first outpatient clinic who was blind. And you can see partly the reason for this as he had kissing Prerygia. And that's one of the questions which I understand you'd like to discuss later on.
Yes.
But it wasn't just him. He came in one day with his mother, who also had severe Prerygium on each eye. And then his brother, who'd had it removed previously and was left with a restrictive esotropia because of the scarring from the recurrent Prerygium. And there were so many other patients. This gentleman, blind from a Prerygium and recurrent removal, a 13-year-old surfer, a 9-year-old, and worse still were the patients that I was seeing who were blinded by the treatment for their Prerygium. This gentleman, and he's certainly not the only one, was blinded as a result of radiotherapy, which when I came back to Australia was the principal method of trying to prevent a recurrence. This gentleman, many years later, was blinded in both eyes as a result of mitomycin treatment for Prerygium. I did my best for him. He actually ended up with an artificial cornea, but was later on blind. And then there were all these patients who were left with recurrent Prerygium and severe visual loss. It became very evident to me that compared to what I saw in the US, this was a different disease. and it was a disease that was quite common, and patients were losing their vision. And so about 25 years ago, I decided to investigate this disease and have spent the last quarter of a century on this. When I first came back to Australia in 1986, my treatment for pterygium was a standard small conjunctival autograft. And I'm going to show you, because I think you'll probably think that I'm only going to show you terrible results from other people. Well, think again. This is the post-operative appearance of a patient that I did a small conjunctival autograft. And although there is not a technical recurrence here, the result in my mind is just terrible. When I see these pictures now, I cringe. I think, could I possibly have got such a bad result? Here are some others. These are all my surgeries. And it highlights one thing, that although there's not a technical recurrence in any of those, the cosmetic appearance is totally unacceptable. Now we need to go back to 1965 when I was still at medical school. This gentleman, who none of you will have heard about, wrote the first English monograph on pterygium. He felt he had the answers to this, and his answer was principally the use of radiotherapy. Now, I consider him the father of pterygium knowledge in Australia. He actually got a doctorate for this, and he's to be commended for his interest. Unfortunately, as is always the case in hindsight, a lot of his findings were incorrect, but he did a great job. And he was actually my ophthalmologist when I first needed glasses. And so there is a context here. I can't say that I was thinking about pterygium in those days, but nonetheless, that's where I was led to. Now, you will know most of these people. I'm sure you will. And I try to make the point that I did not come up with my current technique of surgery just out of the blue. I climbed a ladder onto the shoulders of these three people. You will all know Jose Barraquer, of course, because he comes from your South America. Now, he wrote back in 1980 that he thought that it was tenons that was responsible for recurrence, and he turned out to be correct. And then in 1985, Ken Kenyon wrote the seminal article on conjunctival autografting. Now, he was not the first one to undertake conjunctival autografting. In the US, at least, Dick Thoft was that person. But he brought it to the attention of the world, for which we're very grateful. He actually was my mentor when I was working at the Wilmer Institute. He taught me all I needed to know about electron microscopy. And then Schaefer Tseng, who was one of my students at the Wilmer and who has far eclipsed me in all of the areas in which he works as a very bright, innovative thinker, discussed the use of amniotic membrane transplantation. And I may be drawn on that a little later. But he also highlighted for me the fact that tenons was probably a pivotal factor in recurrence. Now, in 2012, I'm making a big leap here of many years. I published 1,000 consecutive cases with this method that I called perfect for pterygium. I had a follow-up. This was a prospective study. I had a follow-up of over 99% of the patients for at least a year, which is a crucial finding. 80% were primary and 20% were recurrent. So that's a very high population of recurrent pterygiums. 200 odd, now we'll show you the figures a bit later on. There's a large number of recurrent pterygium. But what I really would like to highlight, it's saying, is that the size of these pterygia were on an average of 3.7 millimeters. So we're not talking about small pterygia. Of those 190 odd recurrent pterygia, most of them had just had it removed once, but some had it removed up to 9 times previously. The recurrence rate was 1 in 1,000. If you look at confidence intervals, at 95% confidence will be anywhere from 0 in 1,000 to 6 in 1,000. There were, of course, complications, 1 recurrence, 1 strabismus, 1 inclusion cyst, 1 granuloma, and 3 grafts had to be replaced, not because they had a recurrence, because the graft never looked very good. Now, to the current time, I am now over 4,000 surgeries, including the first 1,000. I've now had a total of 4 recurrences in those 4,000 patients. Of those 4,000, over 500 were my treating recurrent pterygia. So I have still not had any more recurrences in primary removal in over 3,500 than that first one I had in the first 1,000 cases. But I have had 3 recurrences in the over 500 recurrent pterygia removals. So that already tells us one thing. Your first go at pterygium is your best go, even with this method. Now I'm going to do something which is highly unusual, because people usually show you their best results. I'm going to show you the worst results. So I'm going to show you the 4 recurrent pterygia that I've had in the last 4,000 patients. This is the recurrent pterygium on your left. Can you see my cursor?
Yes.
Yes. On the left is the primary pterygium. This was the result of my first removal with an early recurrence, but quite clearly a recurrence. This is the final result 8 years after that first recurrence, after I repeated the surgery. So I'm not proud of the recurrence, but I am proud of my second surgery. Now the recurrent pterygium removals. So this young man, 19, already had it removed once before. And this is my removal with the recurrence. As you can see, probably most people would virtually not recognize the recurrence, but I wish to highlight that I am extremely introspective about recurrence. If I get a recurrence, it's reported. And this is the recurrence, and I have followed him for 5 years, and it has not changed. This is another recurrence. You can see here the caruncle is pulled up just close to the limbus, and this is the result. You know, quite a nice result, but there is a minor recurrence. This one is the worst one. This was a multiply removed temporal pterygium with the lateral canthus pulled forward, and this is my result. He's disappeared from sight. I can't blame him. I offered him further surgery and he decided not to come back. So I can't tell you what he looks like now. Now, the essence of the surgery is that we divide it into 3 stages, which is pretty obvious. But it is the extensive tenonectomy that I will claim is the principal reason for the low recurrence. I don't believe any of the other things about limbal transplants. We'll come into that. It's if you do an extensive tenonectomy, you will have a low recurrence rate. Now, I do other things in the stage 1. I remove the semilunar fold, and we may not have time to discuss this, but I preserve as much of the limbus as I can. Here is the, the bare sclera above the medial rectus, below the medial rectus, and this is the removal of the semilunar fold. But until you remove this, I have removed nothing other than the head of the pterygium on the cornea. Well, what does this do? We can discuss this later on if you wish, but it leaves a huge defect over the medial rectus, almost to the inferior rectus, and less extensive to the superior rectus. Well, I believe you have to cover that. To cover that, I need a large, thin graft. And you can see here that the defect is from there, back to here, and across here. And this is the area of pterygium removal. It's a gossamer, thin, transparent piece of tissue. And you can see that I've actually left limbal tissue intact here. I do not take limbal tissue. But you can see this area is without any cautery or other manipulation. This is how it looks after I have removed a large conjunctival autograft. And once again, we can discuss that later on if you wish. This is the graft sutured in place. The only points I would like to make is that with this technique, using glue is absolutely impossible. It will not work. You will not get a good result. And this is all sutured in place. Back here are 2 posterior sutures which recreate a semilunar fold. And when we talk about the cosmetic appearance, this is the reason that we get a good cosmetic appearance. Because here is a suture of the graft to the residual conjunctiva with a running suture. And you cannot prevent a scar formation. Anyone who does other surgeries on the ocular surface where you suture conjunctiva to conjunctiva will know it may not be a large scar, but there will be a scar. By recreating a semilunar fold, I hide the scar under the newly recreated semilunar fold. I would like to make the point that I have reached the stage of surgery where I basically do not even think about the possibility of a recurrence. Now that may sound full of pride or hubris, but it is true. Occasionally in a recurrent pterygium, as you've seen, a recurrence can occur, but it is very uncommon. We're talking just on 1% of recurrent pterygiums or less. So I don't think about recurrence anymore. This technique gives me virtually 0 recurrence. And I challenge any of you to tell me that you have a method that is that low a recurrence rate. What I do concern myself about is how good is the eye going to look. I want an eye that looks as close to a normal eye as possible. And that's where I want to spend the last few minutes. I've written these 2 articles in Ophthalmology and Cornea about the way I have tested the appearance of the eye, and I'm not going to go into those in detail. Now I'm going to show you some good results, all right, having shown you the poor results. These are consecutive primary pterygium removals. I'm going to go through them fairly rapidly, not because you need time to study them. I cannot avoid some corneal opacity in some patients. But I would challenge you to actually see a post-operative patient even at the slit lamp and tell that they have had surgery. Of course, recurrent pterygium is different. I cannot promise the same cosmetic result for a poor recurrent pterygium like this. This gentleman has had a nasal and temporal pterygium removed on each eye a total of 24 times. How he actually kept on going back, I have no idea. This is after my removal of all 4. Now, he is very happy with the result. Do I consider this a good cosmetic result? No. This is what I grade as a fair cosmetic result. There are abnormal vasculatures here, a few here, but there is no recurrence. This lady had had this terrible recurrent pterygium removed 3 or 4 times previously. This is the post-operative result. I'll go through these quite quickly. Here, the upper lid is bound. There is no fornix here. The upper lid is bound to the eye after multiple removals, and this is him with a normal lid closure now. These are 2 Chinese patients, exactly why they were removed in China. Here is the gentleman with his upper lid firmly, this is his punctum, and he has this tight adhesion, his caruncle is pulled over, he can't move his eye out. This is after surgery, and this is a reasonable upper fornix, all done in the 1 surgery. Of course, he has poor vision. Here is another Chinese lady. This is the punctum, the upper lid. You can see the results. Now, I've undertaken an unpublished study, which I hope will be published shortly, so I can't give you great details, otherwise I'm not allowed to publish it. But I decided I needed to see what the results were after 10 years or more after the surgery. Of course, this is a very difficult study to do. I was following 351 consecutive surgeries. I was only able to examine 77% of these. That's percent, not numbers. There were no further recurrences. The cosmetic appearance was good in more than 95% and no further complications. This gives me some confidence that I'm not doing something during the surgery that's going to result in a bad outcome down the line. I'm now going to once again show you the worst outcomes of these long-term follow-ups. Here is someone post-operatively, more than 10 years after surgery, no recurrence, but scarring that was unacceptable. Here is another such patient. Not too bad, but also scarring that I consider unacceptable after a primary removal. And here is the third patient who had, I'm sorry, the difference in color, who had both a left and right pterygium removal. So I'm showing you the very worst of the cases and another. And these are the ones that brought the good recurrent or cosmetic appearance down to 95%. Now, I'm not going to show you this at the present moment, but we'll come back to this. What does the future hold? Well, if you want to see this firsthand, because I know there are a few people out there saying, this Australian's not telling the truth. I'm not suggesting any of you would be cruel enough to tell me that, but you're welcome. Once this coronavirus thing is over, you can't actually fly to Australia currently. It's no international flights for anyone other than a returning Australian. So you'll have to pretend you're an Australian if you wish to come. But when this is all over, if I'm still performing surgery, you're welcome to come and sit in on clinics and watch surgery. You can't assist or actually perform surgery, of course. I'm happy for you to email me with any questions you might have. And I know the next one will strike you as most unlikely, but I'd be foolish not to suggest this. If you have multiple recurrent pterygiums that you feel are beyond the technique you're using, you can send them to me. I get patients from all around the world. I haven't had any from South America yet, but I have them from the US, from Canada, from Europe, and you know, they're all the difficult ones. There are very few primary pterygium. So anyway, that's the end of my formal talk. I do have a 15-minute video of the procedure, which after we've, you know, I think it might be more useful to actually talk about the cases you want to talk about or answer questions. But if there's time at the end, I'm happy to show the video if you wish, or if the Zoom meeting can be extended for people who wish to watch it, I'm happy to put it on at the end. So that's the end of my talk. Now I've got to somehow stop the share. There we go.
Okay, well now, thank you very much, Dr. Hurst. Dr. Victor Perez just joined. Thank you, Victor. How are you? I don't know if we can hear
Good to see you again.
So, Dr. Hurst, before we present you the cases, can you walk us through what is your pre-op evaluation? Like those patients, the few patients with pterygium recurrence, did they have anything in particular that you wish you treated before? For example, rosacea or some other pathology that you find it's important to treat before operating? And what's your post-op protocol for these patients?
Okay, I can lump together primary and recurrent pterygium to answer this question.
Okay.
Because I'm sure you're aware, I was a corneal surgeon first. I dealt with ocular surface diseases for many years, for decades. I recognize that many of my patients have dry eyes, have rosacea, have a spectrum of allergic component, and frankly, it doesn't change my treatment. However, it does change what I tell the patient. If they have rosacea, for instance, I make sure they understand that even though I believe I can successfully remove their pterygium and that horrible redness nasally will be gone, they will still have occasions of rosacea flare-ups where both eyes will become a bit red. I make sure that they're aware of that. So I would like their eye to be as quiet as possible when I operate. But frankly, I do not go ahead and do anything specifically prior to surgery. Now, as far as a recurrent pterygium, to isolate those from the primary, there are many aspects of the pterygium itself that I need to be aware of before the surgery. It will both modify what I tell the patient and may make a modification to the surgical technique. And we can talk about that a bit later if you like. Post-operatively, they all actually have the same post-operative management. I see the patient on the first day after surgery. I see them 1 month after surgery and 3 or 4 months after surgery. Now, it's do as I say rather than do as I do. In the past, for the first 1,000 or 2 patients, I followed them for a year. I now no longer follow my patients from a year. And once again, this sounds filled with hubris, but patients don't want to come back at a year when I've already seen them at 4 months and they look perfect. They won't come back. So although I believe if any of you are doing studies, you really need to follow patients for a year, I no longer follow them that long, unless at 4 months, they don't look perfect. If they don't, I follow them all the way through to a year. And there are some patients who have fallen into that category. My medication use is, I use the strongest steroid we have, which is what you have too, prednisolone forte. And it's used for the first 3 weeks every 2 hours while they're awake. I believe post-operative steroids are vital in reducing inflammation. Then it's reduced to 4 times a day. They're on antibiotic drops 4 times a day for 1 week only. Now, having told you all this, I'm about to change this post-operative management for one really specific reason. In the past, I have exclusively used 8.0 or preferably 9.0 vicryl sutures. And as you know, they will stay there for 4 or 5 weeks, which is unnecessary. The graft will be firmly attached within 2 weeks. So I don't want a suture there. Shafat Singh has quite elegantly shown that that's the last source of inflammation, and he is correct. The whole graft will be white, but there'll be pockets of inflammation around the suture. So what I am doing now, and it's a compromise like everything in life, I am now using 8.0 Velosorb. Now, Velosorb is similar to Vicryl Rapide, which we can't get here. Velosorb will be gone in 2 weeks, and that's a tremendous advantage. So I am about to reduce my steroid because these patients come back at 1 month and they already look superb at 1 month. So I'm going to reduce my steroid use dramatically in the next few months so that they're only using steroids for 4 or 5 weeks rather than 9 weeks. And the benefit of that, of course, is to reduce the risk of steroid steroid glaucoma induced by steroids. So that is a recent change. It's not in my original description.
Okay. And I'm gonna share my screen, but before we jump into this, anyone has any other questions?
Guillermo, there are so many interesting questions. We have a lot, but for example, Cesar Uribe asks, what is the best treatment for Dellen corneal post-Prerygium surgery?
Sorry, for what?
What the best treatment for cornea Dellen after Prerygium surgery?
Right. First of all, of course, you try to prevent a Dell. And the way I do that, I have had Dellen, all right? So I'm not trying to sound smart that I haven't had them. I haven't had any in the last 5 to 10 years. But what I do is, first of all, I recess the graft at least 1.5 millimeters back from the limbus. So when the graft swells, which it always does do, and it can be quite swollen at 7 to 10 days, they don't develop a drying area in front of the graft. So that's a really critical way to reduce the risk. It doesn't totally remove the risk. I've lost the screen anyway. The second thing is that I ask the patients to call me immediately in the first 2 or 3 weeks if they have any ongoing symptoms, because these patients are pretty comfortable by 2 or 3 days. In fact, it's a bit of an aside to the Dell question, but my patients, 80% of them, and I'm not pulling figures out of the air, each of my patients is put into a prospective database at the time they see me. 80% of them require no pain relief after the first night. 80%, no further analgesics. So they're fairly comfortable. They might have some irritation. They call me and I see them if they have any increasing symptoms, which most people have if they have a DEL, not always. And my treatment for the DEL is to really lubricate them heavily. But as I've said, I tend not to use contact lenses, amniotic membrane, all the things that people have used for DEL, because it isn't a common problem. It is a very rare problem now. I've had one really severe DEL in the last 2,000 patients.
Okay, all right.
Good.
So I think the key points of your procedure is the extensive removal of the tenons and getting a very thin graft. Is that how will you summarize this, Dr. Hurst?
Yeah, that plus the reconstruction has to be very specifically undertaken. So yes, it certainly is an extensive tenonectomy. I go back to just short of the orbital fat nasally. I go down close to the inferior rectus, but not right to the inferior rectus, and less so superiorly. You saw the amount of bare sclera above and below the medial rectus. The graft has to be so thin that you're leaving the tenon superiorly absolutely intact. So we're doing two separate things. In the area of the pterygium, I'm removing extensive tenons. In the area of the graft retrieval, I'm leaving tenons, hopefully with no trauma at all, so that there's no bleeding. And that gives you not only a graft that is very thin, but it does one other important thing. It means the area will be epithelialized in 10 to 14 days, and in 6 to 12 months, you can go back and retrieve a second graft from there if you need it for a double-headed graft. That tells you that, in fact, the first retrieval was atraumatic. And the reconstruction, the two radial suture lines between the graft and the residual conjunctiva have to be sutured to the superficial sclera, nothing in between. The nasal suture line, which I've said leaves a scar, has to be hidden under a semilunar fold. And that way you will not be able to tell. I can tell you a little trick. If you saw one of my patients and you wanted to assess whether they've had the surgery, you won't be able to tell it by looking at the donor site. If you want to look at the pterygium site, and this is on the assumption that they have no corneal opacity, which I cannot avoid in some patients. Let's assume most of the patients don't have a corneal opacity. If you put fluorescein in their eye, you will see a very faint pooling area in the two radial suture sites, even though without fluorescein, you would have no idea they were there. That's one trick. The second is if they look to the extreme lateral, you will see the scar under the semilunar fold.
Okay, well, thank you. Let's start with the clinical scenarios. As we introduced you, there are many members here in the panel that have a strong interest in Prerygium, and within all of us, we'll give you different scenarios. For the people that joined late, just want to say thank you again to Dr. Hurst because he supported Pancornea. This is the second time, and we appreciate that. This is when Dr. Perez was the president of Pancornea, and we did a symposium in Guadalajara, the WOC. So it was in Guadalajara. This is a picture of the of Dr. Hurst enjoying some tequila there. So this is when this paper was very, very popular and shared the technique. And I personally started incorporating it in my practice for some cases, not for all cases, I have to be very honest. I want to know, and many of the members of the panel and the audience, how would you approach a kissing Prerygium? You kind of mentioned it before, how would you do it? But if you had a patient like this, would you do it at the same time? Would you do one and then the other one? Would you consider an amniotic membrane?
Well, I showed you one that was even worse than this.
Yes.
As the first patient I found in my outpatient clinic. I have to tell you, at that time, I was doing routine conjunctival autografts, and I haven't shown you, he didn't get a recurrence, but the cosmetic appearance was terrible. The principle that I use in this, and I wrote about that in Cornea about 3 years ago, 20 double-headed pterygia that I removed, so you could go to Cornea. But I will virtually always remove, I will always remove them separately. I will usually start with the nasal pterygium for technical reasons. And I will do exactly what I've shown you. I will then wait 6 to 12 months and go back and do the same thing for the residual pterygium.
Okay.
Now, I understand that amniotic membrane is touted because you can do both at the same time. But I would like to highlight for you that amniotic membrane just by itself results in over a 30% recurrence rate. So I think it's a no-goer to just do amniotic membrane so you can do both of these together. So that's my method.
Okay.
I've done it in over 20 patients. I've reported the method with no recurrence.
Okay, great. And you don't use, you'll never use mitomycin, or is there a specific? Okay?
I will never use mitomycin.
So you agree with Dr. Karp?
This will offend many of the people listening to this. But you saw, to have a patient blinded in both eyes by mitomycin for pterygium, I find that inconceivable, even if that only occurs 1 in 100 patients or 1 in 1,000 patients. I would consider that as a totally unacceptable complication. I should add that in Australia, and I'm sure this is the same in some countries in South America, pterygium is an extremely common condition. Here in Queensland, 10% of the population over the age of 18 have a pterygium.
Oh.
It has promoted a view by most ophthalmologists in Queensland that this is a trivial condition because it's so common. Mind you, I can cynically say that cataract is just as common, and it's not treated as a trivial condition, but pterygium is. The number of people here in Queensland who will just scrape off the pterygium while they're doing their cataract surgery is unbelievable. So there is a philosophical approach to pterygium, which is incorrect here in Queensland. But what they want to do is a fast, simple surgery. And you achieve that by avulsing the pterygium and using mitomycin. You can do that in 5 minutes.
Yeah.
But how they can sleep at night and live with themselves in the possibility that their patient will look like the ones that I've seen with mitomycin, I don't know. So no, I've used mitomycin in glaucoma surgery, in ocular surface squamous neoplasia. It's not that I won't use mitomycin, but I won't use it for pterygium removal.
Thank you. Next, we have Dr. Maria Iriarte from Uruguay. Maria, muchas gracias por unirte. She has a specific question for you, and I'll leave it up to Maria.
Hi, everyone. Thank you very much for this invitation. For me, it's an honor. And I want to ask Dr. Hurst, what is his management in glaucoma patients? If you will change your technical approach on glaucoma patients only on drops, or will it be different if the patient has already our glaucoma filter and blebs?
Well, this is a fraught question. It's another one that the amniotic membrane people will use. Of course, we can't possibly touch the superior bulbar conjunctiva because it might be needed for a trabeculectomy or a valve. In the past, I would, if someone had established glaucoma, I would take an inferior graft just to avoid that possibility.
Mm-hmm.
I have to say that now I will still take a superior graft. I believe that if I can go back and reharvest a second graft from the same site, it's indirect, it's not direct evidence that I'm leaving the area pristine. Now, I have also run the statistics on this.
Mm-hmm.
And the likelihood in my practice that someone comes to me with a pterygium and no glaucoma at the time and is going to require glaucoma surgery later in life because they develop it is less than 1 in 3,000.
Mm-hmm.
So it is a very small odds. And I have to say that my experience now with superior bulbar donor site suggests to me that it will not be a problem if this person comes to need glaucoma surgery.
Mm-hmm. And do you have any experience with the tissue taken from the pterygium itself, like it is described in the, can you?
Yeah, is the next, yeah, sorry, this one.
In this one, the authors described taking the tissue from the pterygium itself as a graft.
Well, well, Dr. Hurst, we're gonna pause for a minute. María, ¿lo puedes explicar así en 20 segundos al público esta técnica?
Bueno, lo hago en español, ¿no?
Sí, por favor.
Bueno, en estos papers lo que describen los autores, el primero es de Singapur de 1999 y el segundo es de Journal de India de ahora del 2018. Lo que hacen es una resección del tejido conjuntival del propio pterigion, lo resecan bien finito y después lo que hacen es hacer la resección amplia así del atenon, pero reposicionar ese tejido que sacaron primero en el tejido, en el lugar del pterigion, digamos. O sea que usan esa conjuntiva del pterigion superior como injerto, ¿no? En el primer caso, lo que hacían, en el de Schaap, lo que hacen es rotar y poner la parte que iría hacia el limbo, la ponen hacia la carúncula y no tuvieron muchas recidivas. Y en el último paper, que es del 2018, lo que hacen es directamente colocarlo de la manera habitual, sin rotarlo, también con buenos resultados.
Okay.
What I want to say is that here in Uruguay, or Hearst, we only have glycerol preserved amniotic membrane, and that is not good quality. That's why, for example, in my practice, when I have a glaucoma patient, I used to take inferior conjunctiva with good results. But I think that perhaps in your hands, of course, you don't have any scar conjunctiva, superior conjunctiva, but I am worried about this. That's why I am taking inferior conjunctiva, and I don't have many severe complications.
Yes, two things. One with respect to this rotational autograft and one with respect to the inferior conjunctiva. I have had some patients with severe recurrent pterygium with no nasal conjunctiva at all, the caruncle pulled up to the limbus, that when I do my release and tenonectomy, there is a huge area to cover. They've already had superior conjunctiva used. I may be able to retrieve some superior conjunctiva, and I have, as I've said, occasionally done it from inferior. But in the severe recurrent ones, I've sometimes, not often, had to combine two sources for the donor material, superiorly and inferiorly, to get two separate grafts. And I have also occasionally done what Donald Tan writes about here, which is actually keeping the head of the pterygium separate. I don't actually recess it all, keeping the head of the pterygium, flattening it out, and using that conjunctiva as well to cover the defect. Now, you have to understand, because I have such a successful technique, I struggle to change it dramatically because I don't know what it's going to change in the results. So when I actually use the head of the pterygium, which I have done, I don't use it over the sclera. I use it on the inside of the lids to release symblephra formation, because it doesn't bother me what the appearance will look like. I want a functional effect. I believe it's quite feasible what he describes, that you might be able to use the head of the pterygium, but keep in mind that unless it's a very large pterygium, you won't have enough conjunctiva, even if you unfold it, to cover the large defect you get by a large tenonectomy. But I don't think the conjunctiva in the head of the pterygium has any special negative connotations. You know, it's been written in the past that right in the head and the conjunctiva are pterygium cells. Well, I don't believe that. And I believe you can use the conjunctiva. You won't get a recurrence if you've done a large tenonectomy. I just don't have personal experience to tell me how good the cosmetic appearance will be. So I won't use that routinely, but I have incorporated that for severe recurrent pterygium where there is not enough conjunctiva.
Excellent, thank you very much.
Guillermo. Hello, Guillermo.
Víctor.
Hey, Andrés, ¿cómo estás? Muchas gracias.
I can answer that question very simply.
That was very good. Laurie, I want to thank you.
Yeah.
From the board of Pancornea, thank you. So it's so great to see you in these circumstances, and I want to thank you for being here with us, and Guillermo for organizing this great presentation, and Andres, thanks for your support for Pancornea.
Thank you. Thank you, doctor.
And I have to run now. I have to go back to the surgery to deal with another pterygium. No, I'm just kidding. But thank you so much, really. Laurie, great to see you. And before I leave, I want to emphasize again, I think the role of controlling inflammation is very important in the postoperative status of techniques that we use. I think developing new anti-inflammatory therapies that might be more friendly user for wound healing will help the recovery of these surgeries. And I think you have another topic on this, right, Guillermo?
Guillermo, you are on mute.
Perdón,
Ah,
sí, Víctor, Noé Rivero de Argentina va a hablar sobre tratamientos adyuvantes para prevenir la recurrencia.
Perfect. All right.
Okay. Gracias, Víctor. Que
Okay,
vaya bien todo en
Thank you
quirófano.
so much,
Okay.
Victor.
And
Okay,
Laurie, great
Andre.
to see you. And yeah, be safe.
Bye-bye. Andre.
Yes, well, I think, Dr. Laurie, this is a very common scenario, a patient with pterygium and cataracts. So what is your opinion? How do you procedure in these cases? We want to know a little bit.
I don't think there should be any dispute about this. It's 100% clear that you do the pterygium first and the refractive procedure, whether it be cataract, PRK, LASIK, smile procedure, secondly. I don't know how anyone who's doing, I mean, cataract is now a refractive procedure. And you want to end up with a patient who has minimal to no glasses. I don't know how any cataract surgeon can rationalize, and we're not talking about a trivial pterygium, okay, but any significant pterygium, how they can rationalize doing the two procedures at the one time. It makes no sense whatsoever. I mean, all refractive surgery is elective, non-urgent surgery. You know, no one we're talking about here has, you know, is blind from cataract. So they expect the best result. You cannot get the best result by combining the procedures. I mean, a year ago, I had a patient who had a refractive lensectomy in both eyes 2 weeks apart. The surgeon decided to remove a nasal pterygium. Of course, I don't know the size of it because I didn't see it beforehand, at the same time. First of all, it shows an attitude of mind that a pterygium is a trivial procedure, because I can assure you that people that do this as a combined procedure are not taking the pterygium surgery as serious. It's a trivial thing. The cataract is the important factor. This patient came back a year after the surgery. He'd had nasal and temporal pterygium removed on both eyes combined with the refractive lensectomy. 2 out of the 4 pterygia had recurred, and I needed to remove those, and it changed his refractive correction. It's a no-brainer. I can't imagine the situation where someone needs both of these done at the same time.
Absolutely agree. Thank you, Dr. Hurst. Thank you so much.
All right. Well, this is a question that we're getting from the audience frequently now. How would you approach this patient had pterygium in the right eye, conjunctival autograft, not using your technique, and ended up with what most people will call decent. Maybe you won't, but in the left eye, had 2 recurrent pterygiums, now has a symblepharon, and it has, as you see, you know, complete restrictive strabismus. And is this a patient that will you'll use your technique and a mucous membrane graft for the eyelid, or would you consider any other options for this patient?
I mean, I've already shown you a couple of patients like this from China, and I've done a considerable number. I have never had to use amniotic membrane. Now, let me put this into historical perspective. I was working with Schaefer in Baltimore when the concept of amniotic membrane first came up. So when I came back to Australia, I was producing my own amniotic membrane. You know, I was going off to the women's hospital and collecting placentas and doing the whole thing. And I have to say, I have never had to use amniotic membrane in those over 4,000 patients. I've been able to achieve a release of this restriction by conjunctiva alone in every patient. I have never had to do second surgery. All done. However, this is one of those patients where I may well have to keep the conjunctiva from the pterygium. I may have to not only go above but below to actually provide sufficient tissue to give them a deep fornix. It's a bit complex here. You'd have to actually see one of these, but there is a specific order of surgery here. Of course, you have to relieve the symblepharon first because you won't be able to get to anything else. But what you then do is preserve every bit of conjunctiva there is. For instance, this from the lid margin to here is perfectly usable conjunctiva. So when you release this, you fold that conjunctiva back onto the inside of the lid. It won't give you a complete cover. You may need some more in the fornix, and I will always use some through the fornix lid sutures to keep the fornix in place during the healing process. But this is the ultimate difficult recurrent pterygium. Make no bones about it. When I speak with a patient who has something like this, I tell them that it's going to take me 2 hours to do this. Now,
what's your average surgical time for the perfect technique?
All right, for a primary pterygium, mostly it takes me 40 minutes. It can take me up to an hour depending upon, I'm not a skilled surgeon. So if you think that the results you're seeing is a result of a very talented pair of hands, you're mistaken. I have very ordinary surgical hands. I've seen people who operate with far greater finesse than I can. However, it is when a primary pterygium goes perfectly, I'm sorry to use the term again, it will take me 30 minutes. That's the quickest I've done it. Not because I'm trying to achieve a record time. It means if it takes 30 minutes, my hands have done what my brain tells them to do, and I don't have to replace a suture. Everything has gone beautifully. Generally speaking, that's not the case. I have to replace a suture or two. I get a hole in the graft, a variety of small complications, and I deal with them. And that's why it takes me 40 minutes to 45 minutes. But a recurrent pterygium is a spectrum of disease. There are some recurrent pterygia that I remove that are frankly no more difficult than a primary pterygium. It depends a bit on how they were first removed. And then there are ones like the picture you're showing me, which is going to be ultimately difficult. I'll give you an example. About a month ago, I operated on a lady who had already had her pterygium removed 4 times previously. She'd had 3 grafts and mitomycin on 1 or 2 occasions. And her superior conjunctiva was so scarred that I was extremely concerned whether I would be able to achieve a satisfactory graft, to the extent that I told her something that I've never told a patient before. I said, look, I want to do this under general anesthetic because I feel that I may need to go to your other normal eye to get a reasonable graft. And I've never gone to the other eye to do it, but I was so concerned. You might have to with this eye. I don't want to give a patient bilateral peribulbar anesthetics. And I haven't said that in the procedure, but all of mine are done under a full peribulbar anesthetic. They would be running off the table within 5 minutes if I didn't do it that way. But this is as difficult a recurrent pterygium as you're going to find. It takes time, patience, and some knowledge, and easily could take 2 hours to correct this situation.
It took me 2.5, so yeah.
Well,
All
there
right.
you go.
I'm gonna keep moving. So this is another
Well, that
case
was a nice result.
Thank you. We're gonna keep moving so we can cover all the next
I
part.
can stay as long as you like. When I
Well,
get too
me too,
hungry,
but-
That sounds great.
Oh, that sounds great. Then, well, I can tell you for this one in particular, I follow your advice of removing all. This is a year out, but I remove all the tenons as much as I could. I did use a mucous membrane graft to fix the lid and an amniotic membrane. So you're gonna put me in your bad list, but I'd used it. I felt like for the conjunctiva of the lid of the tarsal conjunctiva, I had to use a mucous membrane graft, and that's what we did. That's the difference.
Well, but that's perfectly acceptable. You won't see the bulky buccal mucosal graft on the inside of the lid, so that I have no problems with that. I just haven't had to do it.
This is just to show at recurrent pterygium. With this patient was complaining of restrictive strabismus, but you cover it already. So the next few slides are about the use of fibrin glue versus autologous blood. I think Maria has experience, so I want her to share her experience with the audience in Spanish, and we'll give you a little break if and Maria nos puedes decir cómo haces lo de la sangre. En resumen, los estudios han mostrado que la fibrina, el pegamento de fibrina ayuda comparado con suturas de vicril en estudios de metaanálisis. Y María tiene experiencia en este artículo, que es el uso de sangre autóloga. María, gracias.
Bueno, la verdad es que yo empecé a hacerlo porque acá en mi ciudad no es posible que los pacientes consigan el Fibrin Glue, y la verdad es que con las suturas realmente los pacientes son muy sintomáticos en el postoperatorio. Entonces, una vez que me enteré de esta opción, empecé a hacerla y la verdad es que tiene muy buenos resultados. La diferencia con pegarlo con el Fibrin Glue es que demora un poco más. Uno tiene que dejar una cantidad necesaria de sangre, no es solamente una finita capa de sangre, sino que es un poquito más. No puede ser mucha porque el coágulo porque el injerto se mueve, pero tampoco muy poca, y hay que tratar de dejar el injerto bien desplegado y mantenerlo en el lugar más minutos que con el Fibrin Glue. Pero la verdad es que los resultados son buenos y los pacientes realmente tienen muchísimo menos síntomas al día siguiente que cuando uno los deja con suturas. Y la verdad que las complicaciones más graves que he tenido es que alguno que otro se me ha desplazado completamente el injerto cuando los pacientes se rascan, no tienen muchos síntomas, o que hay a veces un poco de retracción del injerto. Esas son las complicaciones más importantes que he tenido, pero la verdad es que la recurrencia es bastante parecida a cuando hacemos un autoinjerto con suturas.
¿Lo dejas parchado bastante tiempo? Por ejemplo, si la cirugía la haces al mediodía, lo ves hasta el siguiente día al mediodía con el parche
Sí.
20. Sí, ok.
Sí, parchado y apretadito, ¿no?
Ajá. Perfecto. Okay, Dr. Her. So Maria just shared her experience using autologous blood because of the circumstances in her country. She's been happy with that technique, and I personally, in my visits to LB Prasad, I've had many of the surgeons from India using this technique, and because of the difficulty in some places to get fibrin glue. I personally use fibrin glue in my ocular surface surgery. I liked it. So Noé at the end is going to talk a little bit about also fibrin glue. So I'll keep going. This is a topic that you publish and others, and here at Bascom Palmer.
Can I make a comment on fibrin glue?
Yes, please.
Now, I have used something called CryoSeal, which is an American machine where you take the blood from a patient that you're going to later do Prerygium surgery, and you spin down their blood and process it, so you're actually using their own fibrin glue for obvious reasons of safety. I can tell you that with my technique, it's impossible to safely use fibrin glue. You know, even in the ones where I use CryoSeal, I still put 4 sutures in. I find it difficult to rationalize how you can have a 1 to 5% partial or total dehiscence rate in a graft. I have never, and this is absolute, I have never had to go back to surgery with a patient within the first few weeks because something has gone wrong with their graft. Never. I need to sleep well at nighttime, and I know when I see the patient the next day, their graft will be in place. That's one issue. The second issue is that it is impossible to get the apposition I require to the paracaruncular conjunctiva and the superior and inferior edges with glue the way I want it to be to give the cosmetic effect I want. So what's the rationale for using glue or autologous blood? It's because it's fast. You don't need to know how to suture. That's the only advantage. Well, from the Swedish literature and subsequent, there'll be less pain. I've already told you, my patients don't have a lot of pain, so that's a non sequitur. But, you know, the issue of speed and ease of accomplishing the surgery is relevant to the surgeon. It's not relevant to the patient. The patient wants the best end result they can get. They don't care whether the surgery is simpler or quicker. So I don't see the rationale for using glue or fibrin, autologous fibrin, and it won't give me the result that I need.
Okay. Thank you for sharing that. Anyone in the audience has an opinion about this, or we should... Okay, so in the US, at least here in Florida, when we do a removal of tissue, we need to send it to pathology by legally. So, but not in every country. So, do you recommend sending tissue now that we have OCT and Carol Karp and others have shown us very well to screen for possible OSSNs? Would you recommend sending every pterygium to path or not?
Can I tell you a little anecdote which will explain my attitude? You have seen up on the screen the lead article from 2012 Ophthalmology on my 1,000 consecutive cases. You might be interested to learn that the first time I submitted that to ophthalmology, it was actually flat out rejected. And why was it rejected? Because one reviewer, and I hope the reviewer is not in this audience today, suggested that no one could get that sort of good result with pterygium removal, and what I was doing was removing panqueculae. Clearly, I wasn't removing pterygium. Fortunately, the editor saw the wisdom of the ways when I showed him that the average size was 3.7 millimeters over the limbus, and it was then finally accepted as the lead article. So it tells you in one sense that if I had had to justify that it wasn't panquecula, the fact that I sent these all off for pathological examination is one reason why I do. Not for this article, of course, but as an audit of my surgery. So similar to what you were saying, Guillermo, is although we are not absolutely legally bound to send it, most surgeons will send off any specimen they remove, whether it be an appendix or a pterygium, for pathological examination. Now, I have to say that despite the fact that we reported on a 10% ocular surface squamous neoplasia incidence since, I don't find that particular incidence now because when we published this study, we had a pathologist who had done a study together with Dick Green at Wilmer to make sure that he was appropriately diagnosing OSSN. The current, he retired. The current pathologists have really no experience. We don't have really truly ocular pathologists here as you do in the States. So now I'm basically getting virtually no OSSN back in my specimens. And I don't know, I could look at the specimens myself because I have a lot of experience, but I don't change what I do even if there is OSSN in the specimen, apart from telling the patient and the referral source that this exists. And if they get a lump in this area later in life, they need to consider the possibility it's a recurrent dysplastic lesion. So I still send all of mine off, but with less conviction than I had previously.
Okay. I'm going to try to keep going. A lot of people in the audience are asking for your video, so I want to leave time for the video. So,
Sure.
So we cover steroids. You were very aggressive with that. We know your position on mitomycin C, which I personally deal with a lot of complications from mitomycin C. So I share your. I don't know if someone in the audience is against that, but I think it's not, at least not for every primary. And 5FU, I have no experience. These are all medications or interventions that are published in meta-analysis. But Noé Rivero, surgeon from Argentina, wants to share with the audience and with you his experience on using cyclosporine. With anti-VEGF, we've had some experience using it early on for recurrence, but definitely not beneficial when the recurrence is already established. So Noé, thank you very much for sharing your experience. Bienvenido. No te escuchamos.
Pterygium is inflammatory disease, and corticoid is essential in the therapy of this pathology. I use in Argentina, we have diflupernato. Diflupernato is a steroid for more better than prednisolone, and I use for the post-operatory, and it's well for 1 month. And I combine cyclosporine for 1 year in the for the post-operatory, and I have great results. 3 years post-operatory, and I have received less than 5%. If you look in PubMed or Cochrane, you found some articles, and there was a very interesting article who looked 2,000 eyes with 14 interventions difference, and the rank for the best or worst treatment to prevent recurrence say the conjunctival autograft and cyclosporine 0.05 eye drops. What do you think, Dr. Hirsch?
I have no experience with using anti-VEGF or cyclosporine for post-Prerygium. I don't wish this to be taken the wrong way, but I don't see any need for that in my patients, considering the vast experience I have and the results I have. I would also say that here in Australia, at least, it may be different in South America. Very few patients are going to take a drop regularly for a year after Prerygium surgery. So I have no personal experience. It may well work, but I don't see the necessity for it. You see, with steroids and the surgery I do, as I've said just before, at 4 weeks, in most patients, the eye is absolutely quiet with no inflammation now that I'm using 8-O-Velisol. So it's hard to explain why cyclosporin should add anything. I'm not saying it's bad, but why it should add anything to a patient where the eye is white and quiet. So I have no experience.
Yeah, I would say that I've had pterygiums that I didn't use your technique and I used just a conjunctival autograft, and the inflammation, it's difficult to control. Younger patient, beefy pterygium, and I've used cyclosporin in very few cases because they started to get a pressure spike, and it's been helpful in some of these cases, but I don't have the numbers that Noé has, and I think in your hands has shown good results, Noé, so I encourage you to do that study and publish it.
And the study, the conclusion of these studies say the best adjuvant treatment, there was a conjunctival autograft with association of cyclosporin and barrier sclera technique to be shown to be discontinued because they have the high recurrence rates.
Yeah, well, I would agree.
And radiation is very aggressive to the sclera, no?
Yeah, I don't think we should do radiation anymore. I think Dr.
Yes.
Hurst will.
Okay. There's virtually no radiotherapy given in Queensland now, and 30 years ago it was the principal method of trying to prevent recurrence.
Well, as a story, the person who was giving the radiation here in Miami many years ago developed cancer on the finger from all the radiation, and he was holding the probe. Complications, I think we are familiar with the complications. The one complication I would like you to talk about is this scleral plaques that we get. Patients that had pterygium, they get referred to us with these plaques, and some of them progress to either infectious scleritis or just a necrotizing culture negative scleritis. So I think it's because of aggressive use of mitomycin or excessive cautery, but would like the members of the panel and Dr. Hurst to comment on this. How do you manage this?
Well, firstly, we wrote probably the largest series of patients followed who'd had radiotherapy. This is going back in the early 2000s. We, in Queensland here, in Brisbane, the only place that could administer strontium-90 radiotherapy was something called the Queensland Radium Institute, QRI. So we had a captive log of everyone who had received radiotherapy. So what we did is we went back 10 years before our study, pulled up 1,000 consecutive patients who had had radiotherapy, and we tried to find these patients to see what had happened. I'm giving you rough figures here. We only found about half of those people and re-examined them. 13% had scleromalacia with calcium deposition, thinning of sclera. 2 of the 2 patients of the 500 had actually lost their eye from endophthalmitis as secondary to this. 2 out of 500 lost their eye for a pterygium. 12% had recurrent pterygium. And it was that embarked me on looking for a different method. And so I have been, if you like, a prophet in Queensland from moving this from radiotherapy being the common method to it virtually never being used. Now, I also have a large paper. I don't have them anymore, but I did have, before I restricted my practice to pterygium, a large patient population of people who had exactly what you show here. my method of treatment may be somewhat old-fashioned now because I've read the literature and the use of tenons and so forth, but I would caution people against simply going in and removing the calcium plaque, because that was the cause for one of the patients actually losing their eye. You get a terrible surprise. You remove the calcium plaque and suddenly you're looking down on ciliary body. So if you're going to remove the plaque, which is what I do, it's always as a preparatory surgery to going and fixing the hole. So when I go and do this, I do it in the operating room and I actually plug the hole with donor sclera and pull the conjunctiva over the donor sclera. I am sure there are other ways of accomplishing this, but it was very successful for me. But it should never happen. And you're right, mitomycin can give you the same effect even faster than radiotherapy.
To unmute. Because of time, I'm going to move forward. Everyone's asking for your video, so I'm going to have Dr. Sabater present the future therapies with tissue engineering, and then we'll move to your video. Alfonso, thank you very much for showing your work in the lab.
Thank you, Guillermo. Yeah, I'm just going to present very briefly a project that we started a few years ago in collaboration with Victor Perez about conjunctival tissue engineering. So basically, our goal was to manufacture conjunctival tissue that could be used especially for those complex ocular surface surgeries where large grafts of conjunctival tissue may be required. So in summary, this concept was based on first obtaining a conjunctival biopsy, either from the patient or from a donor, and then isolating the epithelial and stromal cells, expanding in the lab, and finally bringing it together into a biodegradable carrier. So interestingly, years ago, we started a collaboration with Professor Dietmar Hoedmacher, who works in Brisbane, Australia. So he might be your neighbor. He works at QUT, and he developed a technique called melt electrowriting that allows to manufacture 3D printed biodegradable scaffolds. So these scaffolds have a very high resolution. Fibers can be thinner than a micron, and also we have the ability to control the fiber deposition, which is critical to control the internal pore size of the scaffold, and this really facilitates cell integration. And we can use also medical grade material such as PCL, which may facilitate regulatory approval. So as you can see in the video, this is a combination of electrospinning and fused deposition modeling. Basically, the polymer is fused, and then a high voltage is applied at the tip of the extruder. So these membranes can be translucent depending on the pore size, and as you can see, they're very easy to manipulate, and we have even tried, and you can also suture them. Guillermo, can you please go to the next slide?
Sure.
Yeah, so as I mentioned before, we did a study where we took conjunctival biopsies from human corneal scleral donor rims. We took the conjunctival epithelial and stromal cells from those samples. We isolated them, we expand them, and we also characterize them. So then we took the stromal cells, we seated them on the scaffolds, and waited until the membrane was completely repopulated by the stromal cells. And finally, the epithelial cells were seated on top of the membrane. So as you can see on that confocal microscopy animated reconstruction, the technique allows us to generate what could be a conjunctival replacement. And basically, this is just what I wanted to share with you today.
Thank you. Thank you. So this will be ideal for when you don't have enough conjunctiva, right, Alfonso? And
yeah, that's right. Especially for those cases where you need a large amount of conjunctiva for, again, I guess, more complex reconstructions, especially also for patients with large symblepharons. This could be an interesting alternative.
Okay, so
that's very exciting. I hope it becomes a viable proposition.
Great. Well, thank you to all the panelists. This is the last slide I have for the cases to Dr. Hurst. I think he should show the video and walk us through the video, and the people that are interested can stay so he can discuss the video. I'm gonna stop sharing my
Sure.
screen so you can share your screen.
Right. Hang on. Okay, I'll try to annotate this while we go through. I told you it takes 15 minutes. So it is edited. This is not a genuine through and through surgery. So, you know, I've managed to get rid of some of the glitches. What's happened? There we go. So I mark the pterygium of the limbus and transect it here. And you need to watch what happens with the edge, this edge, as I transect the conjunctiva. You can see it's already retracted. You know, I have a variety of methods of removing the pterygium from the cornea. Now I'm undermining between conjunctiva and tenons. You can see the blades all the way out to the fornix. You can see there are 3 hands in here. I need an assistant. I cannot do this without an assistant, which is a weakness of the procedure, but I'm afraid it's necessary. You can see that's almost down to the inferior rectus. All I'm doing is just separating very loosely with blunt dissection. Now I'm going between tenons and sclera. That happens very rapidly. I now identify the medial rectus insertion, because of course there's always the risk of damaging this if you don't, with the extensive tenons removal. I'm just making sure I have isolated the tenons layer. If there's any further adhesions, I lyse them now. And then I start excising. You will be able to see how much's been excised if you look through the conjunctiva. And this is just below the medial rectus. And you can see I'm still in tenons here, no fat, but you can see I'm constantly pulling on it. And you can see how much. Now I do the same above the medial rectus. I use a drill, but you can use any method you like if there is enough residual tissue. Now I'm excising the semilunar fold. But you can see the large defect in the conjunctiva before I remove the fold. I've put a suture around the medial rectus. Now I go and excise further tenons back to the fat. You can see just how clean the sclera is. That's how clean the sclera needs to be above and below. I'm now going below. Once again, extensive clean sclera. I now retrieve the second stage, the graft. Marking is a vital part of this surgery. We may not have time to really discuss that, but I couldn't do this without marking. I now inject balanced salt solution between tenons and conjunctiva. You can see how I've just raised conjunctiva. Tenons has been pushed flush with the sclera, back against the sclera. There are 2 or 3 vital components to this successful surgery. There is a secret tunnel here. It's a sweet spot. You've got to find the right place where the conjunctiva can be freely elevated from tenons back posteriorly. If you get into the right space, you'll have no problems at all. You can see there are 3 hands needed throughout this entire procedure. I wish I could design the procedure so it did not need an assistant. Instead of cutting, you can almost strip the tenons from the back surface of this graft. I'm not doing it here, but you can. I train other surgeons to do this procedure, and this is probably the most difficult stage of the 3 stages of the surgery, to get it a crystal clear graft and the underlying tenons not being damaged at all. It's not written about very much, but there is a difference between the adhesion of tenons nasally and temporally. This is a core conjunctival clamp used by glaucoma surgeons. But it's a large graft. Most of these grafts are about 13 by 13 millimeters up to 15 by 16 millimeters. The regular graft done in Queensland, because I've done a survey, is 4 by 6 millimeters. So this is 8 times the size. And you'll see that I leave limbal tissue intact. You do not need a limbal transplant. Now, you can see also that there's no bleeding. The tenons is totally intact. The marking means you will never reverse the graft, which is the great concern by the people I'm teaching. You'll see I recess it about 1 millimeter in this case, millimeter to 1.5 millimeters. I'm going through sclera. These are the points that you cannot do with glue or autologous blood. This graft will never come loose, never. Now, this was the days when I was using 9.0 Vicryl. As I said, I now exclusively use 8.0 Velisol. 8.0 is a bit thicker than I would like. I would prefer 9 or 10.0, but it doesn't exist. But I'm quite prepared to live with 8.0, considering that it's gone in 2 weeks. Here is the posterior suture. Of course, this is the suture where if you're not careful, you could create a disaster. If you penetrate the sclera, you'll have a retinal detachment. So it's done in 3 stages, through the graft, through the sclera, and then through the recipient conjunctiva. And this above and below creates the semilunar fold and hides the scar. I have to say, if I was to claim any innovation in this surgery, it's this simple, small technique, which I haven't seen reported anywhere else. It's hardly a great move forward, but together with the tenonectomy, which others have suggested, it makes it all possible. So this, I can't remember, will be back about 14 millimeters or 15 millimeters back from the limbus. Here is the other corner. So as you can see, my hands are just mildly talented. I'm certainly not one of those gifted people who can do virtually anything the first time. But I find now here in Australia that a lot of the residents can barely stitch at all, because of course they're doing the cataract surgery without stitching. I have to train them to stitch. Now I close the radial incisions, and this is through sclera as well. As I said, this scar you get from here, in 3 months, I would challenge you to see it unless you use fluorescein, because there is a little dimple line.
That's how you preserve the semilunar fold right there, right? Putting that under.
Sorry, those two back stitches will create the semilunar fold. We haven't finished that yet.
Okay.
You cannot get this sort of closure with glue. Yes, you might have initially at the table, on the operating table, the whole thing aligned, but you cannot get it firmly stuck, the graft and the recipient conjunctiva, to the sclera and have it stay there. It doesn't matter if there is a little gap in sclera here, makes no difference at all. In fact, it's a smaller side. If you have a hole in the graft here, you just leave it alone. You don't need to close it at all, because you're over bare sclera. It will adhere to the sclera, and you will never be able to see there's been a hole. And you'll also not see these. If it's over the muscle, I will put if there's a hole in the graft over the muscle, I'll put a suture in, because the last thing I want is muscle fascia poking through a hole in the conjunctiva, because then you can get a granuloma. And I have had an occasional granuloma, no question. But I don't know if you remember, but in the initial article where Solomon described the amniotic membrane use, and there was a 32% recurrence rate, they also had an enormous number of granulomas. I can't remember, it was something like 5 or 10% granulomas. The only reason that amniotic membrane works now from Schaefer's group for Prerygium is it's not because of the amniotic membrane, It's because, yes, he does an extensive tenonectomy, with which I agree entirely. He uses mitomycin. He will frequently use a small conjunctival graft. He will close the gap with glue, and he will use post-operative injections of steroids. I mean, if you can tell me that says that amniotic membrane is working, I can't rationalize that. Now, of course, with all those modalities, the recurrence rate is acceptable. It's under 2 or 3%. But the recurrence rate with this method is 1 in 1,000. And you don't have to use amniotic membrane, mitomycin, post-operative steroid
the surgeons that have been visited you and are doing this technique that you personally train are getting the same results, Dr. Hertz?
Yes, they are. Now, there's here we're closing the semilunar fold, or it's underneath the semilunar fold, because the 2 back stitches are further back. So when the eye looks in the primary position, this scar is folded underneath the recreated semilunar fold. It's interesting. It's like the prophet in their own land. I don't know if that's an expression you understand in South America, but when you try to bring something new in your own country, they don't want to even listen to it. And so, although I've gone around to every state in Australia and requested people to come forward and train with me, in 8 years, I've managed to find 4 people. I've trained 3 of them fully. I'm training the 4th. It's very disappointing. But yes, they are getting similar results.
Yeah.
It's not easy surgery. You know, I tell my patients that this is major surgery. And obviously, I can use a very prime example. If you have your cataract removed, it'll be done in 10 minutes. With me, it'll take 3/4 of an hour to do this surgery. And I've done virtually every complex surgery on the front of the eye. You know, I've done 13, 15 millimeter corneal scleral grafts. I've done intraocular tumor removals. A bad recurrent Prerygium, like the one you showed me of yours, Guillermo, remains one of the most difficult surgeries I've ever done. And you've got to have that mindset. If you go in expecting simple surgery, you aren't going to get these results. So there you go. When the eye is turned in, can you see the fold?
Yeah.
That's the new semilunar fold. And in most patients, you can't tell that you've put a suture line there. So that was 14 by 13. Sorry, it's out of focus. You can see it's recessed slightly. And you can see there's an opacity in the cornea, which I can't remove at surgery because it's in the corneal thickness itself.
Okay. Well, that was very elegant. Thank you. I only have one comment. I think that do you feel if we had a better classification for pterygiums that could predict which cases are going to have different, more aggressive healing or complications, that we could use this technique for only because there are some cases on patients that are 75 years old and had a very atrophic pterygium that maybe with just a regular conjunctival autograft it's enough. Would you agree with that? If you had a classification that could predict that you would not do this extensive procedure, or because I feel
I'll answer it in 2 ways. One is I do the same procedure on everyone, no matter how small the pterygium is. And I'd like to just come back to that point. But I can't argue with the fact that a routine small autograft with an appropriate amount of tenons removal may be perfectly satisfactory for a small pterygium in a patient who doesn't care about the appearance. Sure, I think that's perfectly reasonable, but you understand, from my viewpoint, having such a successful procedure, I would go into the operating room being extremely anxious if I did anything other than that procedure, because that'll be the patient where I'll have a result I don't want. Now, I'd like to make a point, and I hope this will not be taken the wrong way, because here in Australia, we're very sensitive about sexist comments, all right? And I know in the US you are too. So you might consider this a sexist comment, and for that, I apologize ahead of time. But you know, I've traveled extensively in South America, and from my masculine male viewpoint, the women in South America are amongst some of the most beautiful women in the world. My eyes were out on stalks when I was walking around Brazil. I have to say they're beautiful women. And I think if you're going to offer them surgery for pterygium, they deserve nothing less than the best cosmetic result you can give them. So please take that on board. I hope you're not offended.
Thank you very much. Anyone that wants to give any comments, I think, from the panel?
No, I think it's a great technique, and the results, I mean, are amazing, right? I mean, we saw this, we were watching these cases, such severe cases, and then when you see the results, it's amazing.
I agree. Well, Dr. Hurst, thank you very much for waking up so early, and to everyone in the audience. Andres, I'll leave it up to you to post the webinar and see if there's any questions.
Thank you, Guillermo, for all your job, your works. It's amazing. Thank you for being part of Ophthalmic University. Thank you, Pancornea. I want to thank all the speakers, Maria, Noé, Alfonso, of course. Thank you so much for being here, and especially Dr. Hurst. I think that today we are all a little bit better in the pterygium field, and that is because of you, Dr. Hurst. Thank you so much. I'm sure that Latin America is very grateful with you and this lecture.
Well, thank you very much for inviting me. I consider it an honor to speak about pterygium.
Thank you all. Tomorrow, remember, we have the talk with Gustavo Servino, a survivor of the Andes tragedy. And thank you so much for the assistances and all of you guys. Thank you.
All right. Bye-bye. Thank you.
Thank you.
Thank you.
Bye-bye. Thank you.
Bye.